going to share my screen. Okay. So welcome everybody. Thanks for having Martha and me. And we're excited to present on conversations on palliative care, coordinating between inpatient acute rehab and home-based palliative care. I don't know why this. We do not have any disclosures, and today our objectives will be to describe the difference between a palliative approach to care and specialty palliative care, identify palliative care needs in populations with a variety of medical diagnoses, and explain what our program is and how our program supports patients and families in transitions of care. Oops. And just wondering through, I don't know if people feel comfortable putting in the chat any information about themselves, but wondering, how many social workers, how many case managers, how many other people from other health professions, how many people from the community are here, just so we get a sense. And Martha, if you can monitor that, because I can't get, while I'm sharing the screen, I can't get into that piece. And we will go through our presentation. If you have questions, you can feel free to put them in the Q&A portion. We're going to try to hold questions until the end. We're going to have, 10-15 minutes at the end to hopefully chat together about palliative care. So Martha, if you want to take it away.
So just in response to the people are putting into the chat, it looks like there are a lot of social workers here, a few nurses, but it really looks very heavily social work.
Great.
So that's great. Thank you for people.
We are great.
In the chat. Yes. And it'd be very happy. Oh, we have a few case managers. It's all still coming in, so it's hard to kind of keep track of it all. But I'll start. So good morning, everybody. I thought it would be helpful for us to start with a definition of palliative care so we can all kind of know what we're talking about as we go forward. And just in case you're ever on Jeopardy and want to know the history of palliative care in North America, the concept of palliative care was brought to North America in the mid-1970s by a Canadian physician, Dr. Balfour Mount. And he was a surgeon, a cancer surgeon actually, who went to England and worked a little bit with Cicely Saunders, who was the founder of hospice. And then when he came back to Canada, he was at McGill University. He thought, he really came up with the concept of having care for people with serious life-threatening illnesses earlier on in the trajectory than is provided on hospice. So he kind of is considered the father of palliative care in North America. And since the mid-70s, when the palliative care movement started, it's actually it's taken a while, but it's been growing since then. The word palliative comes from a Latin word, to palliate, which means to cloak or to veil. So in palliative care, the focus of care is to help with the symptoms and the burdens of serious illness, not to cure the illness. So that's just another little interesting tidbit. So anyway, what is palliative care? So palliative care is a medical specialty. It can also be an approach to care. It's a person and family-centered approach aimed at improving the quality of life for seriously ill patients and their caregivers. Palliative care tends to the physical, functional, psychological, practical, and spiritual consequences of serious illness. It focuses on assessment and management of pain and other symptoms, assessment and support of caregiver needs, and coordination of care. Next slide. Palliative care, as I said, is in a philosophy or an approach to care as well as a medical specialty. It is delivered in a variety of settings, and over the past 15 years or so has had has spread beyond the hospital into community settings, long-term care, and other areas of care where there are people suffering with or dealing with serious illness. So, as I said, the palliative care can be considered an approach to care, or a organized medical specialty. Palliative care has been recognized as a medical specialty, but to clarify the differences is that a primary palliative care is considered palliative care that is provided by clinicians who are not considered to be palliative care specialists. A primary palliative care should be provided by all clinicians who are caring for seriously ill patients. And it allows for informal discussions about patient and family values and goals. It also helps to provide a space to organize medical decision-making and care planning. And it helps to promote stronger patient clinical relationships and reduction of fragmented care. So specialty palliative care, on the other hand, is provided by palliative care specialists, usually doctors who have board certified in palliative medicine, nurse practitioners who have certification in palliative care, or social workers who are certified in with special certifications in palliative care. It's generally considered to be, ideally it is team-based. There is physicians, nurses, social workers, chaplaincy, all involved on the team in helping to care for the patient. Specialty palliative care is often reserved for the more complicated cases. And specialty palliative care started in hospitals, but has now expanded to other settings, outpatient clinics, home-based care, home-based specialty care, and palliative care and long-term care and acute rehabs. So right now, the specialty palliative care workforce is, there's basically not enough special palliative care specialists to go around. And a lot of the palliative care interventions and skills can be provided by in a primary palliative care pattern, or considered a palliative approach to care. So most patients throughout the country don't have access to specialty palliative care. I mean, we're in Boston. It's a big medical center. There's probably more of us concentrated here in this area, but if you move out of the big metropolitan areas or where the tertiary care hospitals are, there are very few palliative care specialists. So it's important that anybody caring for seriously ill patients have some knowledge of palliative care and are able to see the patient with more of a palliative lens into their care. It's recommended by the AHPN and other palliative care organizations that all that primary palliative care be provided to all seriously ill patients, as I said, and that people who care for seriously ill patients have basic training on assessing and treating physical symptoms, addressing psychosocial and cultural issues related to serious illness, and are able to have serious illness conversations regarding what matters most to the patient and what their goals of care are and understanding of the illnesses. There are curricula being developed to try to really promote this primary palliative care so that palliative care is available to more people who are dealing with serious illness. And also the curricula is intended to empower clinicians who do not consider themselves, specialty palliative care trained or with real palliative care skills to use the skills that they probably have in dealing with seriously ill patients. We know that acute care does not always address or consider the needs of the actual patient. And care is usually based on acute care just because of the nature of acute care, coming into the emergency room and or going to the doctor with acute symptoms are really the decisions made in general are based solely on the diagnosis and don't always result in desirable outcomes, and also can have potential to increase treatment burden and other complications. But a palliative approach to the care recognizes that the health care should not be based solely on diagnosis, but consider what the patient's needs are, where they are in their trajectory, what their understanding of their illness is, and what is most important to them in achieving the goals of their care within the illness that they have. Next. So now that we talked a little bit about the differences between a primary palliative care approach and specialty, I just wanted to kind of clarify, and most of you guys probably know most of this, but we always get the question of what is the difference in similarities in hospice and palliative care? And the misunderstanding of palliative care, as I think somebody said earlier, was it gets in the way of people being referred to palliative care because a lot of providers think palliative care and hospice are the same thing, and they feel like people aren't ready for palliative care or because they think that's hospice. So just to clarify, so palliative care in any approach can be involved at any stage of a patient's illness. In palliative care, sometimes we may see somebody who is newly diagnosed with, say, for example, cancer. They're undergoing treatment. They're having a lot of symptom burden because of the treatment and the diagnosis. And we can get involved and help them with symptom management. But there could be a time that all the symptoms are managed and we are able to sign off. Hospice care, on the other hand, provides care for people at the end of life with a 6-month trajectory of illness. So in other words, the provider needs to certify that to the best of their knowledge, the patient's life expectancy is 6 months or less if the disease continues going on the way it's going without any interventions to halt the progression of the illness. Palliative care, we follow along, like I said, with people who are having treatment. They might be undergoing chemotherapy, they might be having dialysis, they might be continuing workup for other health issues. And whereas hospice is a time when curative life-prolonging treatments have stopped. So the patient is no longer receiving any what's considered as a life-prolonging intervention. Palliative care is generally a small medical team. And the hospice, on the other hand, is a large supportive team. They're available 24/7 and actually about 95% of hospice care is delivered at home. So this is, the team is available to the patient and family if they have questions or reporting symptoms or changes in condition by 24/7, whether it's a phone call or a home visit. And the palliative care is usually part of a current active medical team or organization. So palliative care programs are usually, not always, but embedded in a medical system or a hospital. And the hospice generally are outside agencies that are not necessarily affiliated with hospitals or medical centers, but they do work with the providing clinicians who have sent in the referrals. So hospice, just another thing, hospice in its is a comprehensive program, which is covered by Medicare. So everybody who has Medicare has, you have people have A, B, and they also have a hospice Medicare benefit. So that the hospice, once someone elects hospice, their their hospice Medicare benefit goes into effect, and through the hospice, Medicare covers any services, equipment, medications that the hospice orders and approves as being part of treatment for the patient's primary end-of-life diagnosis. All insurance, I think it was as of 1995, the government said that all insurances have to have a hospice benefit to them. So because Medicare was the most established hospice benefit already, most insurances model the Medicare benefit. So even though we talk a lot about hospice, Medicare benefit, all health insurances have some kind of a hospice benefit. We can do the next slide. So we say, why do we need palliative care? Well, we need palliative care because, first of all, our population is aging. The number of baby boomers is increasing. We are going to probably take over the world by 2040 with a gigantic increase in the over 65 population. Chronic conditions and disabilities are on the rise. So with increasing age, these conditions increase. And by 2030, 80% of Medicare recipients will have one chronic condition and 50% will have two. And that's pretty significant because even if you think of, somebody with, one chronic condition like congestive heart failure, that can really impact your life. And really there's a trickle-down effect from the one condition, which usually then affects every other part of your ability to your health and your function. Half of community dwelling Medicare beneficiaries are homebound in the year before they die. And that is generally due to chronic conditions. And one condition that we don't always consider is just frailty. Frailty in itself is a diagnosis. People are at home, they're frail, they're unable to get out of the house. They don't really have one specific thing that you can pinpoint is medically wrong, but their general debility and frailty really affect prognosis. And then 40% of Medicare recipients have 40% of homebound patients have a 2-year mortality. So those are pretty staggering numbers. Another reason why we need palliative care is that healthcare utilization is increasing because the numbers of older people with chronic conditions is increasing, and healthcare costs are increasing for the same reasons. So we ask, why home-based palliative care? So palliative care provided in the home setting is associated with reduction in symptom burden, increase in patient and caregiver satisfaction. And there have been studies that have shown that that's where this information has come from. People who have home-based palliative care involved have a decrease in hospital utilization at the end of life and have a decrease in healthcare utilization and cost. Also, what studies have shown is that patients who are involved with home-based palliative care, for whatever reason, diagnosis, whatever, tend to, there's a marked increase in earlier referrals to hospice. So people followed by home-based palliative care tend to access their Medicare hospice benefit sooner in the disease trajectory, and they do have a longer length of stay on hospice. And we did a small study on our team a couple of years ago, and that, our findings supported what all the other studies have shown. And the benefit is this longer length of stay on hospice is actually, first of all, very advantageous to the families who have the benefit of hospice over time, and not just the, as we said, the deathbed referral when people, get on hospice and die right away. And also it helps the hospices because financially that's how they're set up. They're set up to follow patients over time and to have the patient, incrementally need more services, which then helps. It goes along with the model of how hospice was intended to be. Increasing hospice utilization, like the stay, also just anecdotally is helpful because it will help it helps to dispel the myth that hospice is just for people who are going to die right away. So it really helps to support the palliative care, the hospice industry, as well as helps the patient and family. So models of care for home-based palliative care are, there's a primary palliative care integrated models. This is the most robust model. There are a few that I know of around the country where they integrate primary care and palliative care into the same practice. So the primary care team is following the patient. They also have access to comprehensive longitudinal palliative care with palliative care specialists on the team who are available to see the most complicated patients and also are able to help teach and support the rest of the provider team with that palliative approach and primary palliative care. Another model is the home health-based model, and that's models that are rely on the infrastructure of the home care. So, and not like the visiting nurse programs. Some of the programs have nurses and social workers with special special training in managing seriously ill patients at home. They may be certified as palliative care specialists, and they work in a traditional home care program, which is the intermittent, I'm trying to think of the words, but the intermittent home care, they have to follow the same, guidelines though as like Medicare, and so they're not necessarily able to stay in longitudinally. And then there's the hospice-based, hospice-affiliated model where freestanding hospices will have palliative care specialists who are able to see patients who may not be medically ready for hospice, psychologically ready for hospice, or might be undergoing curative treatments or palliative things like palliative treatments that would preclude them from being on hospice. And then once they're ready for hospice, they can smooth transition right into the hospice program. And then there's the consultative model, which is what we are. And we provide interdisciplinary specialty palliative care as consultants to the provider who referred the patient to us. And I think now Annie's going to talk a little bit more about that.
Yes, hi. So the MGB Home-Based Palliative Care program, we, as sort of Martha started to describe, we're a medical consult service for MGB patients. We see patients in their home. And I think, sort of stereotypically, people think about palliative care and hospice really in the oncology world. And while that's definitely true, and where, maybe some of these concepts got some of their legs and sort of got their start, I would say the majority of our patients have a variety of other complex medical and functional problems. So we see a lot of patients who have end-stage renal disease, heart failure, COPD. We do see patients who have cancer, often more often than not in concert with these other issues as well. And I would say the majority of our patients have some kind of cognitive question, whether they have a formal diagnosis of dementia or they should have a formal diagnosis of dementia, but they don't, or they are going in and out of delirium, or they have dementia and delirium, or, sort of combinations of reasons for cognitive changes. That is a huge thing that we uncover in most of our patients, I would say. And our program is made up of a medical director who is part-time. We have four full-time nurse practitioners, and then I'm the social worker. For the program, we have one triage nurse who is part-time with us and part-time with another part of the Mass General palliative care division, and then 2 schedulers and program coordinators who kind of help with the admin stuff. And we go to people's homes, and we go to assisted livings. We are not credentialed to go into nursing homes or rehabs. Let's see here. So we see patients who are part of the MGB system. So they either have an MGB primary care doctor, or they have a very highly involved outpatient specialist who they are involved with, and the reason for that is because we need to have a clinic or a physician that we are consulting to, that we're working, in concert with. And so that's why, we really need to keep it within our system. And then, we cover a specific geographic area that's over to the right. If you want to take a look at that, it's mostly Boston and the surrounding areas. And we help in a, kind of a, in a variety of ways where we're, often, patients, as they get sicker and more infirm and more frail, they're not coming into the clinic as often. Or if they are, it's like that's the big outing for their week. And so they look very different than they do in their own home environment. And so often just going into the home and getting a sense of what is the full impact of this person's declining health and functionality on their life. That is a major piece of data that we're able to get just by going into the house. And also, kind of evaluating family caregiver needs, who else is involved, from community organizations. We assess prognostic awareness, discuss hopes and worries. We support medical decision-making as, in sort of a longitudinal way. That can involve things like filling out a MOLST form, where that goes through advanced directives like DNR, DNI. It doesn't always involve that. I think that there's sort of a stereotypical thought of like, oh, we'll get palliative care involved. They'll get the patient to be a do not resuscitate. And, sometimes that happens, but sometimes we are helping a patient confirm that they in fact want to be a full code, even though that's not, maybe medically recommended. Their decision is their decision, and we support that, whatever that might be. We do active symptom management and coordinate very closely with the other members of the patient's care team. We support caregivers, and really are also looking to optimize any things that we can do, or any care that can be provided in the community. We do facilitate transitions onto a hospice team, and again, we do help with completing MOLST forms, and not most importantly, but very important, looking at healthcare proxy forms, making sure someone has it, that they're filled out correctly, that they're scanned into the system. So this is how to reach us. You can always call our office, the number there, if you have any questions about, gee, I have this patient, I'm not sure, what do you think? Or you can email us. And if you are a Spalding or an MGB provider, and you want to put a referral into us, you do that through Epic, through that way to do it, through Epic. And now we'll move into our case study. Just quickly, someone asked how our program is billed and will insurance cover it? Yes, so we bill like a clinic. So the nurse practitioners bill for medical visits, and it is covered through insurance. I do not bill because our program, my role isn't really set up for billing. There's as I'm sure all the social workers here know, there are specific ways in which social workers can bill. And that's changing, but it's still pretty narrow. So I don't function as a psychotherapist in this role, so I don't bill.
And Annie, somebody just asked if you could just go back to the last slide for a second about how to reach us. Here we go.
Great.
So our office is MS General, and we do have, as Annie said, we work with MGB providers, but I would suggest if you have a patient and you ever had a question about whether or not we could see them, you could always call our office and get some, get answers to your questions. But we are limited to our geography. We tend not to, we just don't have the bandwidth to go beyond our geography. But our office also has information about other palliative care programs outside of the our geography, and some that are within the, outside our geography, and for patients who don't have MGB providers.
You want to start with the case study, Martha?
Sure. So we have a case study, with just to kind of bring this all together. We have a patient, her name is Goldie. She's a lady from Ireland, and she was referred to us in the fall of 2021. With and the referral followed a discussion she had with her primary care doctor regarding a new diagnosis of a lung nodule. And she, of course, her PCP suggested she have a CT scan and have follow-up. And the patient said she didn't want any of that. She doesn't want any treatment. And then the patient asked the doctor about having palliative care because her sister has palliative care. I actually followed her sister, and she said, well, my sister has somebody coming in. Can I have that too? And that really is what prompted the referral to us. So we met with her. This is now 2 years ago, and shortly after that, she was hospitalized for COVID, and she had a really very complicated COVID course, and she came home, and she was on hospice, and so she came home to die on hospice because of COVID. Other things to know about Goldie is that she lives alone. She's in a second floor, really nice apartment, but it's a walk up. There's no elevator. She has a very involved family, but it's kind of a complicated family dynamic. And she's also had a history of a stroke. She has COPD. She's legally blind. And she is really experiencing some debility in her ability, functional decline. She's had a consistent functional decline since we've known her. She had a few hospitalizations. I'm sorry. So she recovered from COVID, which was pretty amazing. And then we started seeing her again in the summer of 2022. So, and since then she's had 2 hospital admissions. One was for a chest pain with a new MI, and the other was for influenza. And amazingly, she has been able to come home and is now resumed living at home. But each time she's sick, she's got a new baseline of function and cognition. And because of her symptom burden, and the psychosocial issues regarding her need for independence and family dynamics, Annie has become involved in the case. So I'll let her take over from here.
Yeah, so I did a joint visit with Martha, and after one of her most recent hospitalizations for a fall, where she now has some wounds on her leg that VNA is also sort of concurrently involved doing wound care. And, Golda is a woman who um, has been a caregiver for her entire life. She came to this country to care for a family member who was having a medical crisis. And then she stayed and, got married and had a life here. But her whole sort of identity, her whole life has been around her physical and emotional strength and her identity as a caregiver and as a very independent person. So this decline that she has been on now for several years has been really emotionally disorienting and really painful for her, because in many ways she's got so many medical problems and there's so much changing so quickly. But on the other hand, it's changing quite slowly. The decline, it's now been a couple of years, and I think her ability to find meaning in her daily life is getting harder and harder as she's needing more and more help herself and isn't able to be present in her family life and in her own life the way that she wants to be, the way that she used to be. And so that's a big thing that she struggles with. And the changes in her cognition kind of highlight that struggle, because she'll sort of start a sentence and start talking about something and then get lost and then have a little bit of insight into that, and then kind of talk about how this isn't how she wants to be, this isn't how she wants the end of her life to be. And she'll often talk about hoping for a quick death, hoping to go to sleep and die peacefully in her sleep. And we hope that for her as well, and it hasn't happened. But anything else on Golda?
Well, and I think too, in supporting her, like from a nursing perspective, or a medical perspective, I've worked with her over the years on symptom management regarding her, COPD, her shortness of breath, her for a while she has some neuropathy. We've treated that for a while. Basic, constipation. We've worked on that. Home safety for her. We can't stress that enough. We've had, brought in physical therapy to help her with, home, adaptive devices, home safety, because she has had a few falls. And I think, she wants her death to be at home and be peaceful and quiet, but that generally doesn't happen if you have a fractured hip. And we see that all the time. So really working with her on stressing home safety. And we have involved her family too. There's been times when at the home that we'll call in she's very close with her granddaughter, who is her primary support, to talk to her about our concerns and her concerns, and as a group kind of come up with plans. We recently worked with the case manager in the doctor's office to refer her for elder services to try to increase care in the home. Of course, she begrudgingly is accepting a homemaker, although she really doesn't want anybody. So it's in a way it's a challenge, but also we're trying to really support her in living the life that she wants to live and having the best life that she can with the supports that she has. And we'll see. We have to just kind of partner with her through this and see where it all ends up. One thing I wanted to say, which I don't think we mentioned before, which is also sometimes is a complicating factor when people are coming home from the hospital or rehab, is that home-based palliative care can be provided along with visiting, intermittent skilled visiting nursing care, because we bill separately. We bill Medicare B, and the home care bills Medicare A. We're not the same thing. And even though this is very confusing for patients because I'm a nurse, but I'm not really a visiting nurse. But just for you guys to know that it can be provided at the same time. We do different things. We work a lot with the VNA. Like in this case, I have worked, I've talked to the physical therapist and talking about, what I see and what he sees and what, we think we should do. But we work together a lot, which is nice. And we can, visit at the same time. Sometimes people think that that's a duplication of services. So, but it isn't. So I think we wanted to leave some time for questions and to thank you guys for your attention, and hope that you found this helpful. And I think there are questions in the Q&A or the chat.
Are you saying there are questions in the chat, or
No,
are
I'm
you
asking Michelle if there are questions.
Yep. So it looks like there's one, and it says, "How is your program billed? Will insurance cover for it?" And there's another one after that, but if you want to answer that one first.
Yep. So just to recap, our program is we bill Medicare, and we bill all health insurances. And patients are responsible for, if they have a copay on their insurance, they are responsible for that. But our program is billed Medicare B and the like for other insurances. And so it's billed, and then it's also billed to Mass Health. And
I like this next one. So from your perspective, what can the IRF teams do better to engage with your program?
I think that going back to one of the first concepts that Martha talked about in terms of a palliative approach to care as opposed to a dedicated palliative care team. I think that if you're looking at a case through a palliative lens of sort of asking yourself, what is the goal here? What's globally happening here? This person is in rehab for XYZ reasons, but there's all this other stuff going on around them. I think the way in which case managers, think about how do we put all the pieces of care together. I think that you're sort of perfectly situated with the deep skill set that you guys already have, to sort of be thinking about could on discharge a home referral to palliative care be helpful, and you might need to be kind of nudging your medical colleagues a little bit to be sort of shifting orientations. I think it's very difficult. Case management is very difficult. I'll just sort of state an obvious, but I think that in particular from, especially like places like Spalding, Charlestown, where you're really seeing very acute rehab patients, it's hard to be simultaneously working on getting people better, sort of that's the goal, and thinking, but this isn't getting, this isn't curing. We're not curing someone. This isn't getting any better. How can we address the suffering? How can we address, what's happening? It's hard to hold those two things in your head at once. And, I think institutionally that's hard as well. And, I think also keeping a close eye on is your patient MGB connected? And if so, great. If not, there are some other programs out there, not a lot, but some.
Yeah, I think that's a good point. I work, as I mentioned, I've worked across our network, and I have been at our IRF, Charlestown and Cape Cod, but then also our LTAC in Cambridge. And there's a difference in terms of the approach. primarily with the medical teams on like how they view palliative care and how it can be helpful. So I know one of the questions I always sort of get is, or some of the statements are, this is palliative care is really just for pain management. How do you guys address that sort of those sort of sentiments?
I think, we often get referrals that are specifically for pain management, and we actually don't do that. There's a pain management clinic that's what they do. Obviously pain is one of the many symptoms that we see and that we try to, and that we address in sort of multiple ways. But pain is, you can look at that very narrowly. You can look at it like physical pain. You can look at pain as more of a global pain. And that, helping shift your team or the medical providers who you work with from a narrow to a more broad view. That is a life's work. That is very difficult. And, I think that helping medical providers learn the difference between palliative care and hospice, because I think along with that mindset that you're describing of like, well, palliative care is just for pain, is like, well, they're not dying, so they don't need palliative care.
Right, which is exactly what I've gotten.
yeah, which is like, well, they need palliative care because they're not dying, but they are suffering with a life-limiting illness or a life-limiting thing that has happened that in and of itself is life-limiting. But then, when you have a disease that's going on, and if you have COPD, that's a pulmonary disease that's affecting your lungs, your breathing, but your lungs are connected to all of your other vital functions of your body. So if your lungs aren't working, then, your brain you may not be getting enough oxygen to your brain, or you may not be able to move around a lot. So your skin might start breaking down, or your energy is low, or, you might get depressed. The body is, even when we're healthy, is very fragile, and it's like a domino effect. So sort of helping kind of take the blinders off of our medical colleagues' eyes is it's hard. But that's
another thing. Another thing is to ask the provider if they would to use the surprise question. I don't know if you guys have all heard of that, but to say, would you be surprised if this patient died in the next 1 to 2 years? And if the provider says, no, I wouldn't be surprised, then that's probably a palliative care patient. Because it's looking at it more broadly, but you have these frail elderly people that you're sending out, and maybe there isn't one specific thing, but when you look at them, you're like, they're probably not going to do that well, or they're at risk for falling, or they're going to go home and they're not going to eat. So I think that using the surprise question is oftentimes helpful to kind of, get more of a feedback. And the answer is, and the surprise question has actually been studied too, that if the answer is no, I wouldn't be surprised, that's a palliative care patient.
We have a couple of more questions. Would your program serve a Spalding patient who is cared for by the MGB acutely, but not followed by MGB providers outpatient?
No, you have to have an outpatient.
Not. Yeah, I mean, you would have to look to see too, if they have an MGB specialist that's actively involved, like a pulmonologist, an oncologist, who would be willing to consult with us. But in general, no, we can't take those patients at this time.
The general thing is those specialists have to be outpatient. So you have to have some kind of outpatient, and not just like, oh, I have a podiatrist, who cuts my toenails, who happens to be, but someone who's really, centrally involved in your care has to be part of MGB.
So what if your primary care doctor isn't part of MGB, but willing to coordinate, consult with you guys? Would you consider that? No.
Well,
We've
if the
tried
patient's
that.
going home, they could refer to a palliative care program that is not MGB.
Okay.
Right.
Um,
And,
like the other models that we talked about.
I think that there are, some of the hospices have home-based palliative care programs. Atrius is building a home-based palliative care program. I don't know about Harvard Vanguard, but well, that is Atrius. But so I think that there are models that are
Yep.
out there, and it's better to have something that is closely connected to the primary health organization than to have us hanging out on the outside.
Looks like we're running out of time. Are there more questions there?
One more. Can patients who want to self-pay for hospice enroll? And also patients who are not funded by insurance, are there options for them?
That I honestly don't know, because we're not hospice. My guess is that, I don't know. I mean, I would think you could, if you have insurance, you're going to have some kind of hospice benefit. So, and also people with like the low, I forget what it's called, but like the lowest level mass health, oftentimes the hospice will, provide some limited services. So those questions would have to really be probably case by case and be seen, go directly to the hospice. Somebody put a question here about using, I'm just trying to find it, using the serious illness conversation, and do we find it helpful? Annie, I think maybe you can probably address that, because you do
I do a lot of those trainings. I do find it helpful. I don't think that every patient can tolerate an entire serious illness conversation. And I think that I probably use it differently than, people in the hospital or other places. But I think that having a framework of questions that you can pull from while you're talking to patients, while you're thinking about patients. It's sort of similar to the "would you be surprised" question of, asking a patient, what do you understand of what's happening? That can yield a huge amount of data that you can bring back to your team about what's connecting and what's not. What are you hoping for? What are you worried about? There's a lot that patients hide. They don't share with us unless we ask them. And so I think in that way, it can be very helpful.
I know our time is up. We have so many questions. I'm wondering, Anne and Martha, if people can send some questions to you, or if you could be resources outside of this meeting, because I know this is such a huge topic and discussion, and everyone has a lot of questions still.
Sure.
Yep. If people can certainly email us.
Yeah.
With any questions.
And there's one question that is it true that palliative care is consulted too late in a person's life? And what can we do to get people into palliative care earlier on?
Well, I think what Annie had just talked about, we all talked about, was really, I think educating people about palliative care and having a palliative care lens yourself when you're providing care for patients will help you to be able to build a case for providers to refer earlier for palliative care. And I think really keeping that surprise question at the head of right on the top of your list of things to think about really helps to gauge whether or not the patient is palliative care appropriate. I think I found we get people referred to us who are really not, on occasion, not very often, not appropriate, but we can screen that person and say, okay, well, right now it seems like things are okay. Maybe we'll come back later on if they're stable. But I think you're right. There are a lot of people who who could use palliative care, particularly home palliative care, and are not it's not recognized. And I think we as an industry have to also promote what we have and what we offer, to make people more aware of what is available out in the community.
Okay. I mean, there's one last one if you want to go through it, or shall we just?
Sure.
Okay. So do you find that some of your patients are reluctant to have a social worker involved? And if so, have you found joint visits with CM/RN to be helpful?
Yeah, so most of my visits are joint with the nurse practitioners. And every once in a while we'll run into someone who just adamantly refuses to have me or to have it social work actively involved, like patient, like involved, talking to them. I would, I do a lot of behind the scenes consultation with the nurse practitioners in the program, whether I become, kind of patient facing or not in a case. But people, usually when I'm coming in to a visit, I'll acknowledge I'm actually very nice. People get really scared when they hear a social worker is coming. And I think that we're seeing more people specifically ask for social workers, specifically ask for support, mostly, caregivers, family members who are struggling with trying to care for their, and manage their family members' medical care and physical care and everything. So, it's a delicate dance, I would say. But it's, we do it well, but it every once in a while someone says, I don't want that.
And usually when I see a patient for the first time, I always say, okay, so, basically here's how our program works. This is what you can expect. And we have a social worker on our team who someday will probably come by with me because she comes around and meets all the patients. And I just kind of put it in the package of, this is what we do. And so a lot of people are not, people kind of like, oh, okay. I think I try not to say like, gee, I think you need a social worker, because that's kind of more, then they kind of don't think they want somebody. But I just say, oh, it's part of the program, because I think a lot of times the team needs Annie's insight as to, how to best manage the patient and family's needs. And so it's always great if she can know who they are. And usually you don't usually get a lot of pushback, but sometimes. And then if that's the case, then Annie doesn't go.
Yep.
Okay, I think we've covered most of the questions that I can see. A lot of people put them in the chat instead of the Q&A. But I think, like Cynthia said, if there's anyone that has any more questions, you can feel free to reach out to Martha or Anne.
Yeah.
Great.
We're around.
Yeah.
Always happy to chat palliative care.